Hi guys, welcome back to my channel. My name is Dr. Ria if you are new, and this video is about renal physiology part 2, and these are the topics that we'll be discussing today. If you have not watched part 1, I'll leave the link somewhere on this screen or in the description box below, so do check that out as well. So without wasting any more time, let's get started. So in the previous video we had talked about the renal plasma flow and the GFR, and right now I'll start out by talking about the filtration fraction. So the filtration fraction is basically the ratio of GFR to the renal plasma flow. That means our filtration fraction measures how much of the renal plasma flow which has reached the kidney is actually being filtered and enters the nephron, right? So our filtration fraction is normally approximately 20%. So 20% of the plasma which comes to the nephron should actually get filtered across the membrane, right? That is basically what our filtration fraction measures. So if we can just see the same thing in first aid, filtration fraction is equal to GFR upon renal plasma flow. Similarly, we can also calculate the filtered load. The filtered load of any substance, like how much of a substance is being filtered in milligram per minute, can also be calculated by this formula. A filtered load is equal to the GFR multiplied by the plasma concentration of that substance, right? So these are two very important formulas which you guys should keep in mind. Now, if you remember in the previous video, I had said that we'll be discussing about the hydrostatic pressure and the oncotic pressure and all of those things. So let us start with that. Let us come back to this diagram in just 5 minutes, and before this I'll just make it a bit simple by drawing a schematic diagram. So let us say that this right here is our afferent arteriole, and this right here is our efferent arteriole, right? And we know in the middle we have our glomerular capillaries, right? These capillaries are the site where filtration actually happens, right? The renal blood flow enters through here, and the efferent arteriole divides into these smaller glomerular capillaries across which filtration happens into the Bowman's capsule, and the remaining blood which does not have any more waste then exits that nephron via the efferent arteriole, right? And right over here we are going to have our Bowman's capsule, right? Our Bowman's capsule is the first part of the nephron, and basically this is where our filtrate is going to enter first, right? This is our urine. This is our urine. This is what has entered into the nephron. Alright, so let us now start out by, let's talk about some important terms like hydrostatic pressure and oncotic pressure. Let me assume that, let us denote the hydrostatic pressure by H. Oops. Right, let us say hydrostatic pressure is H and oncotic pressure is O. So guys, I'm sure a lot of you guys already know what is hydrostatic pressure, but let us just revise it. So the hydrostatic pressure, now this is a very simple definition just to make it easier for you to understand. This is not the exact medical definition, but the hydrostatic pressure is the pressure which is exerted by the fluids, right? And fluids exert an outward pressure. For example, water will exert a hydrostatic pressure, whereas the oncotic pressure is a pressure which is exerted by the plasma proteins in our blood. For example, any plasma protein will want to retain the water to itself, right? It will not want to send out the water. It's kind of like osmosis. If you understand the concept of osmosis, then you will understand this very easily, that the hydrostatic pressure is the pressure exerted by, like, water, for example, the outward pressure exerted by water, right? Water always wants to go from the area of higher concentration to lower concentration, whereas oncotic pressure is a pressure exerted by, for example, salts, right, or the plasma proteins in the blood. They will want to keep that water to itself. So in that way, if this is our glomerulus, so the hydrostatic pressure of the glomerulus will actually exert an outward pressure, right? It will want this plasma to enter into the Bowman's capsule, whereas the oncotic pressure of the glomerulus, all the plasma proteins in the glomerular capillaries, they will want to retain all of that plasma. They will not want to send it into the Bowman's capsule. So they will exert an opposite force inwards, right? Now let's similarly talk about the hydrostatic pressure of this Bowman's capsule and the oncotic pressure of this Bowman's capsule. Again, the hydrostatic pressure of the Bowman's capsule will exert an outward force, and the oncotic pressure will exert an inward force in the same way. So, but we know that net we do have some outward force, right? Some outward pressure does exist between the glomerular capillary and the Bowman's capsule. That is why we have a net shift of renal plasma into the Bowman's capsule, which becomes your filtrate, right? So what is that net? What is the net pressure? The net pressure will be, obviously we'll have to subtract the hydrostatic pressure of the glomerulus minus the hydrostatic pressure of the Bowman's capsule, right? Because these are in opposite directions. And then we have the osmotic pressure of the glomerulus is again, we have the osmotic pressure of the Bowman's capsule, right? That is helping us filter the blood into the Bowman's capsule. So osmotic pressure of the Bowman's capsule minus the osmotic pressure of the glomerulus, right? And we have to add these two pressures, because this is your net hydrostatic pressure, which is pushing the filtrate into the Bowman's capsule, and this is the net osmotic pressure, which is again bringing your filtrate into the Bowman's capsule, and this is going to be your net filtrate pressure or whatever, right? Your net pressure. So I hope you guys understood this concept. It's very simple maths. Basically we have to add all of the forces which are pulling the filtrate into the Bowman's capsule. We have to minus it from all the forces which are pushing, which are not allowing it to go into the Bowman's capsule. So we can write it in one more way. If we just add all the forces in one direction, so like hydrostatic pressure of the glomerulus is also inward, and osmotic pressure of Bowman's capsule is also inward. So we can also say that Hg plus Ob, and we can just subtract this net pressure from all the pressure in the opposite direction, that is osmotic pressure of the glomerulus plus your hydrostatic pressure of the Bowman's capsule, right? This will also be the same thing. If you will compare these two, they will come out to be the same. So I hope you guys understood this concept first, and let us see over here in this diagram. This is the same thing, net filtration pressure. Here instead of taking H for hydrostatic pressure, they have taken P, and instead of O for oncotic pressure, they have taken this symbol right here. So they have done the same thing. P is the hydrostatic pressure of the glomerulus plus the oncotic pressure of the Bowman's capsule. These two pressures are pulling the filtrate into the Bowman's capsule, and they have subtracted it by the pressure in the opposite direction. That is, your hydrostatic pressure of the Bowman's capsule will push it away, and the oncotic pressure of the glomerular capillaries, right? So this is your net filtration pressure, and I hope you guys understood this concept. So we are going to apply whatever we learned about hydrostatic and oncotic pressure in this topic, which is changes in glomerular dynamics based on, like, what happens when our efferent arteriole constricts or dilates, and what is the effect it has on the filtration fraction. So this is a very important topic, and it's a bit confusing if your concepts are not right. So let's try to figure this out. So let's see the first scenario. What happens when you have afferent arteriole constriction? Let me just draw a rough diagram for you guys, what we had seen earlier. So this was our afferent arteriole, and this was our efferent arteriole, and this was our Bowman space. Alright, so when your afferent arteriole constricts, right, obviously you're going to have less renal plasma coming into the glomerular capillaries, and of course if less plasma comes into it, less filtration will also happen. So ultimately GFR will also decrease, right? So I think it makes sense to say that GFR will also decrease and renal plasma flow will also decrease. What happens to the filtration fraction? Let us first revise the definition of filtration fraction. It was our GFR upon renal plasma flow. Sorry, I forgot the spelling. Renal plasma flow. Alright, so if your GFR is also decreasing and your RPF is also decreasing, do you think there will be any change in the filtration fraction? No, right? So there's going to be no change in the filtration fraction if our efferent arteriole constricts. Let's talk about the next scenario. What happens when your efferent arteriole constricts? Now this is a bit controversial and confusing one. If your efferent arteriole constricts, for example right here, what happens to the GFR? the GFR actually ends up increasing, and that is because your plasma is not able to exit out as fast as it has entered. There will be an increase in the hydrostatic pressure within the glomerular capillaries, and as we know, the hydrostatic pressure is going to exert an outward force, and that is going to increase the GFR, and that is why our GFR is increasing. And this is only a transient change. This is what is going to happen first, but this change is not going to last for a long time. So although initially the GFR will increase, ultimately it will end up decreasing. But I think in order to avoid confusion, let us remember this instant change, which is that GFR will increase. What will happen to the renal plasma flow? Now, of course, because our renal plasma flow is not able to exit out as fast through the constricted efferent arteriole, there will be some back pressure changes, and because of that the renal plasma flow will decrease a little bit. So the RPF will decrease. Now let us apply our formula here yet again. What happens to the filtration fraction? If your GFR is increasing and your renal plasma flow is decreasing, yes, your filtration fraction is going to increase, guys. Your filtration fraction is going to increase if your efferent arteriole constricts. Third and fourth scenarios are going to be quite easy if you guys understood the concept about oncotic and hydrostatic pressure. So if the plasma protein concentration increases, right? So here this oncotic pressure of your glomerular capillaries, okay? Indirectly, if your plasma protein increases, then there's going to be less filtration fraction. There's going to be less filtration that occurs, because the plasma proteins will want to keep the filtrate all the plasma to themselves. So ultimately your GFR is going to decrease. And however, if the reverse happens, if there is a decrease in the plasma protein concentration, then your GFR is going to increase. But in both of these scenarios, is going to be no change in the renal plasma flow. Hence, what is going to happen to the filtration fraction? In the third scenario, if the GFR is decreasing, then your filtration fraction will decrease, and if your GFR is increasing, then your filtration fraction will increase, right? That's pretty simple. Now let's talk about the fifth scenario, that is what happens when there is constriction of the ureter. Now remember, the ureter is basically where all of your urine is flowing out from all of the millions of nephrons in the kidney. They're all going to combine and they're all going to finally exit the kidneys through your ureter. Now if there is a constriction of the ureter, then again there's going to be an increase, there's going to be a backflow, right? There's going to be a pressure onto your individual nephrons. So indirectly the GFR will decrease because all of the filtrate that's being formed is not able to exit the kidneys, right? So indirectly your GFR in that case will decrease, and again it will have no effect on the renal plasma flow, so your filtration fraction will decrease. And the most important I feel is this one, that is dehydration. What happens in dehydration? In dehydration, your renal plasma flow will also decrease, and because of that your GFR will also decrease. But the decrease in renal plasma flow is more than the decrease in the GFR. Hence, ultimately what happens to your filtration fraction? GFR is, let's see here, if the GFR is decreasing and renal plasma flow is decreasing more, then ultimately net your ratio will increase, your filtration fraction will increase. Okay, so this might be a bit confusing. I want you guys to just listen to this part again and read this again, and it will become easier for you if you just try to understand the concept behind and the reason behind why every change is taking place. Alright guys, so I think now we should move on to renal physiology proper, like what happens in each part of the nephron, the PCT, the loop of Henle, DCT and the collecting tubule. So let's start with that. Alright guys, now let's talk about all the parts of the nephron and each function of every part of the nephron. So here I have just drawn a very basic anatomy of the nephron. So let us just identify the parts very quickly. So this is the Bowman's capsule, and you guys are very well versed with the Bowman's capsule and its function, so we won't talk about that any longer. Next part is this PCT. PCT stands for proximal convoluted tubule. So the word convoluted means that it has this twisted shape. Do you see it's a bit convoluted? That is why it's called the proximal convoluted tubule. And then it flows down into this loop. Do you see this loop? This entire loop is known as the loop of Henle. And it is divided into two parts, that is right here this descending loop of Henle and here the ascending loop of Henle, right? Then more distally we have another convoluted tubule that is now called the distal convoluted tubule, right? Again, because we are seeing this twisted shape. And then finally the last part of a nephron is this collecting duct, which finally exits the nephron via the minor calyces, major calyces and the ureter. Alright, so let us just talk about very briefly and the very basic function of every part. I won't try to confuse you guys by telling you about all of the different functions, but let's talk about the important ones. So first, the PCT. The most important thing you guys have to remember here is that the PCT is responsible for reabsorption of 100% of glucose. Okay, 100% of the glucose is reabsorbed in the PCT, but if you remember from our first video, there is a transport maximum, right? It will not continue to absorb all of the glucose, but yes, up till a level, a certain plasma level of the blood, it will reabsorb all of the glucose. So 100% of the glucose is reabsorbed by the PCT, and not only that, there's also reabsorption of almost all of the 75% of sodium, bicarb, and all of the other ions as well. So let us look at this very important channel, which is the SGLT2 channel. That stands for the sodium glucose transporter, right? So this is a secondary co-transport channel between glucose and sodium. So this is active transport, and through this channel both your glucose and your sodium are reabsorbed into the blood from your urine. Now a very important application is a drug which we, for example, the gliflozins drugs, for example canagliflozin, which are these drugs inhibit this channel. Okay, and when they inhibit this channel, that will cause excretion of the glucose in the urine, and this is used in diabetics, right? Because diabetics already have high plasma glucose. So this is an application of this drug. Okay, so that was the basic and the most important function of the PCT. You should remember that PCT transport is isotonic. That means glucose will be passively reabsorbed as well. You know, for every example, for every 1 unit of sodium which is reabsorbed in the PCT, 1 unit of water is also reabsorbed. So net our urine remains isotonic. It will neither become hypertonic or hypotonic because water is also being reabsorbed as well. Next, let us now talk about our loop of Henle. So we have discussed about the function of this part PCT. Now we move downward into this loop of Henle. Now as you can see, the loop of Henle becomes a bit thin at this part, right? So it's called the thin descending loop of Henle, and after some time while ascending it becomes thick again, and that is called the thick ascending loop of Henle. So both these two parts of the loop of Henle have different functions, and let us see how. Alright, so I have drawn a schematic diagram again for you guys. This is your descending loop of Henle right over here, right? So let us assume this is a thin descending loop of Henle. Now that thin descending loop of Henle is only permeable to water. It is impermeable to sodium and other ions. That means only water is permeable, and water will exit this part of the nephron. Hence we know if only water is exiting and our ions are not exiting along with water, hence the osmolality of the nephron increases as you go down, because as we're moving down, water continues to escape from this part of the nephron, right? So the osmolality increases. That is why this part is called as the concentrating segment. Alright, the descending loop of Henle is called as the concentrating segment because it is only permeable to water and impermeable to sodium. Hence water flows out of this part of the nephron. Hence the osmolality keeps increasing as we move down, right? However, when we come to the thick ascending loop of Henle, the reverse happens. The thick ascending loop of Henle is impermeable to water and only permeable to ions, right? So in this case, your sodium ions will move out, right? When the sodium ions move out and water remains within the loop of Henle, then as you move upwards, your osmolality will decrease, right? And when the osmolality decreases, hence this part is called your diluting segment. Okay, diluting segment. So as we can see, while we are descending in the descending loop of Henle, the osmolality is increasing, and when we ascend, the osmolality is increasing, and this, guys, is known as your counter current mechanism. Okay, This is called as your countercurrent mechanism, and this countercurrent mechanism, this is a very important question asked, that this countercurrent mechanism, where else is it seen? As we can see, it is there in the kidneys, but this countercurrent mechanism is also seen in your testes and in the intestines. Okay, this is a previous year question, so do remember that. I do want to talk about this special channel in the ascending loop of Henle. As I said, the ascending loop of Henle is permeable to sodium, but there is a very special channel here which is called as your sodium potassium 2 chloride channel. Okay, so your sodium potassium 2 chloride channel. So not only sodium but potassium and chloride, these are also reabsorbed via this channel, right? And we have a very important drug which actually inhibits this channel and is used for hypertension. Can you guys guess what it is? So the name of that drug is furosemide. Okay, furosemide is a drug which is used, and it's used to inhibit this sodium potassium 2 chloride channel. Now how this drug works is, by inhibiting this channel there will be less reabsorption of sodium, and we know that sodium is a cause of hypertension. Hence, by using furosemide we can decrease the blood pressure in hypertensive individuals. So you guys will be learning this in medicine and pharmacology. Alright, now we move on to our distal convoluted tubule. You remember that curved part just after your ascending loop of Henle, we have the DCT. And what is the importance of DCT? I want you guys to remember two channels here. So the first channel is this. This is your sodium chloride channel. Okay, this channel is sodium chloride channel, and it is responsible for your reabsorption of sodium as well as chloride. And yet again we have a very important drug which can inhibit this channel as well, and again it is used in hypertensive people because again it will decrease the reabsorption of sodium, and that is your thiazides. Okay guys, thiazides inhibit this sodium chloride channel in the DCT, and hence they do decrease the blood pressure, and actually thiazides are your drug of choice for hypertension as well. Right, and now we have one more channel here which is very important, and that is your calcium channel. Okay, this channel reabsorbs the calcium, and this is called your TRPV5 channel. And since it is responsible for reabsorption of calcium, can you guess two hormones which might act on this channel to upregulate it and cause reabsorption of calcium? These two hormones are parathyroid hormone and vitamin D. Okay, the parathyroid hormone and vitamin D are two hormones which actually activate this important channel, so that there is increased reabsorption of calcium in the body and the calcium level increases. Alright guys, now moving on to the collecting duct. It's very important, and we have a very important hormone acting here as well. So this is your collecting duct. In the collecting duct we have two important cells. The first one you can see is the principal cell, and the second one is the alpha intercalated cell. First let's focus on the principal cell. Now before I talk about what the channels, here I'm going to first talk about the hormone which is regulating a lot of these channels, and that is aldosterone. You guys might have heard about aldosterone, right? So basically let's think of it like this. Aldosterone hates potassium, and aldosterone also hates hydrogen ions, but mostly it really hates potassium. Aldosterone does not want potassium levels to increase in the blood. Aldosterone only wants sodium to increase in the blood. Hence, when there is increased potassium in the blood, when there is hyperkalemia, right, or when there is decreased sodium in the blood, which will cause decreased blood pressure, right? So decreased blood pressure and hyperkalemia, these are two stimulus for aldosterone production. Aldosterone will increase in these two conditions, and what will it cause? Right, so because we remember that it hates potassium, right, so it is going to cause an excretion of potassium into the urine, right? It is going to activate this channel, it is going to excrete the potassium into the urine, and it is going to activate this channel as well. This is your ENaC channel, guys. This ENaC channel is important for sodium reabsorption. Alright, so it is going to cause your sodium to be reabsorbed into the blood, and it is going to cause excretion of potassium. I also told you that aldosterone also does not like hydrogen ions. So as you can see here, right here in this alpha intercalated cell, your aldosterone is going to cause excretion of hydrogen over here. Okay, so these are three channels I want you guys to remember: sodium and potassium in the principal cell and hydrogen channel in the alpha intercalated cell. Okay, now one more thing I want you, one more hormone is there, and that is called ADH, right? ADH is also called as your antidiuretic hormone or your vasopressin. So as the name says, antidiuretic hormone, this hormone does not want diuresis, it wants to prevent your urine formation, it wants to preserve water. Okay, it does not want to cause loss of water in the body. So this hormone right here is going to cause reabsorption of water from the urine, right? And it's going to activate these aquaporin 2 channels. Remember guys, not aquaporin 1, it's aquaporin 2 channels. Now I want you guys to tell me, where do you think aquaporin 1 channels were present? Where before this, did we discuss water reabsorption in any part of the nephron? If you remember, the descending loop of Henle was only permeable to water, right? Right over here. As you can see at this part, right here we have aquaporin, at this part we are going to have aquaporin 1 channels, guys. Here we have aquaporin 1 channels to reabsorb the blood, but in the collecting duct we have aquaporin 2 channels, right? Here we have aquaporin 2 channels. ADH activates the upregulation of these aquaporin 2 channels, which will then cause reabsorption of water into the blood. So guys, I think we have covered all of the important channels, and if you remember at least this much, you will be good to go. So guys, finally we have reached the final segment of renal physiology, and we'll be talking about the regulation of this physiology by the renin-angiotensin-aldosterone system, right? So the renin-angiotensin-aldosterone system, each word is a hormone in itself, and is also called the RAAS system, right, in the abbreviated form. And the basic function of this RAAS system is to increase the blood pressure, right? The ultimate goal is to increase the blood pressure by increasing sodium reabsorption, water reabsorption, and by many other ways. We're going to see now how it is going to increase the blood pressure. So any stimulus in the body anything which causes a decrease in blood pressure, okay, anything which decreases the blood pressure in the body will cause stimulation of this RAAS, and the RAAS will then counteract and increase the blood pressure. So let us just see what all are the RAAS activators. What is going to activate RAAS? So as I told you guys just now, decrease in the blood pressure, decrease in blood pressure in the renal baroreceptors. Our renal system itself has some baroreceptors which are going to be stimulated by the decreased blood pressure, and they're going to activate RAAS. Then we have decreased sodium chloride delivery, which will be sensed by the macula densa cells. Okay guys, so if the macula densa cells are right over here, okay, the macula densa cells are present in your DCT, okay, and the function of these macula densa cells is to recognize decreased sodium chloride delivery to the DCT. Now decreased sodium chloride delivery to the DCT means that there has been a decreased renal plasma flow, decreased renal blood flow, because if there is decreased blood flow, there is going to be decreased sodium chloride, right? And as a result, because there will be decreased sodium chloride delivery to the DCT, it is going to activate RAAS. Right, and the third RAAS activator is your increased sympathetic tone, right? So I think we know that our beta receptors are part of your sympathetic system, and activation of beta receptors causes an increase in the blood pressure, right? So so if there is stimulation of the sympathetic system, again your RAAS will be activated. Okay, so these are your RAAS activators, and let us just talk about the juxtaglomerular apparatus also really quickly, because I think it is very intricately linked. Okay, the juxtaglomerular apparatus. Okay, so first let's talk about the juxtaglomerular cells, okay, after which this apparatus is named. So these are your juxtaglomerular cells, and these are present in the afferent arteriole. Okay, these are the modified smooth muscles of your afferent arteriole, and the reason why they are so important is that they synthesize renin. Okay, they synthesize your renin right over here. So these juxtaglomerular cells will be activated by any activation of RAAS, will indirectly activate your juxtaglomerular cells, because these are the cells which will actually synthesize your renin. So this was the first component of your juxtaglomerular apparatus. The second component is your macula densa cells, which we have discussed also. They are present in the DCT, and they are responsible for sensing your NaCl. Right? If there is decreased sodium chloride in the DCT, then they will again activate your RAAS. And the third component, which is not visible in this diagram, are your mesangial cells. Mesangial cells, also called as Lassie cells. Okay, so these cells mainly have a supportive function. Okay guys, so let us just have an overview again of what we talked about. We are talking about RAAS, renin angiotensin aldosterone system. Each of these words is a hormone, and this system acts to increase the blood pressure. This system is activated whenever there is decreased blood pressure, right? Whenever there is decreased sodium chloride delivery to the DCT, which will be sensed by the macula densa cells. And third, whenever there is an increased sympathetic tone, whenever there is activation of the beta 1 receptors, then again your RAAS will be activated. When the RAAS is activated, your juxtaglomerular cells are going to synthesize your renin. Now let's move on to this part. What is the function of renin? Renin is responsible for converting your angiotensinogen, right? This angiotensinogen means that it is a pro-hormone, right? It is a pro-hormone, and it's going to activate this angiotensinogen into angiotensin 1. As you can see that angiotensinogen is produced by the liver. Now angiotensin 1 will now have to get converted into angiotensin 2. Right, and for this we have a hormone called as ACE hormone. ACE hormone stands for angiotensin converting enzyme. Right, so it speaks for itself that angiotensin converting enzyme will convert your angiotensin 1 into angiotensin 2, and this ACE enzyme is secreted by your lungs and your kidneys both. Okay, now this angiotensin 2 is actually the main hero of our story. Now this is actually going to produce many effects which will increase the blood pressure of the body, right? That was the ultimate goal of activating RAAS, if you remember. So what are the various ways through which angiotensin 2 acts? Let us see one by one. So the first, right over here, as we can see, these are your endothelial cells. Okay, so endothelial cells of your blood vessels. So angiotensin 2 acts on the blood vessels, on the receptors, and causes vasoconstriction. And we know that vasoconstriction leads to increased blood pressure. Okay, that is the first way which angiotensin 2 acts, is by causing vasoconstriction and leading to increased blood pressure. Second, it is going to cause efferent arteriole constriction. Do you guys remember in the beginning of the video we have discussed that when efferent arteriole is constricted, there is an increase in the GFR and there is a decrease in the renal plasma flow, and that will ultimately lead to increased filtration fraction. And so that is how it is going to act. It is going to it preserves the GFR even when your renal blood flow is decreased. Okay, that is the second way how angiotensin 2 acts to preserve your GFR. The third method, do you remember when we discussed all the ion channels in the PCT, DCT, collecting duct? Well, that is going to come into handy now. In our PCT cells, we have one sodium hydrogen channel. Okay, the sodium hydrogen channel works by absorbing the sodium and in return it excretes your hydrogen, right? So angiotensin 2 is going to increase the activity of this channel. Hence what is going to happen is going to lead to sodium reabsorption, and sodium reabsorption is also accompanied by a passive water reabsorption, and that is going to increase the blood pressure yet again. And that is how this acts. And yes, of course, because in return we are causing hydrogen ion excretion. Now whenever hydrogen is basically an acid, right? So whenever the hydrogen ion in the body decreases, it is going to lead to alkalosis, right? So it basically permits contraction alkalosis is what I want you to remember. That is how angiotensin 2 acts on the PCT cell. Now if you remember that angiotensin 2 has a lot of functions in the in your alpha intercalated cells and principal cells also. How? Do you remember that we had a very important hormone in the collecting duct, which was aldosterone? So angiotensin 2 is going to also stimulate aldosterone secretion from your adrenal glands, and when the aldosterone is produced, we know it acts on the collecting duct on the two cells, principal cells and the alpha intercalated cells. We know that aldosterone hates potassium and hydrogen, and it loves sodium and water, right? So aldosterone acts on the alpha intercalated cells to cause increased hydrogen secretion. H plus ions are secreted into the urine, so they're lost, and it acts on the principal cells to cause sodium reabsorption and potassium secretion. And also we know that that in the principal cells we also have water reabsorption via aquaporins, right? And which channel was it? It was aquaporin 2 channels. So there's also going to be net water reabsorption, and of course if water it is reabsorbed, sodium is being reabsorbed, there's going to be an increase in the blood pressure, right? So we have to remember this as well, that RAAS activation also causes an increase in aldosterone. Although the name renin, angiotensin, aldosterone also has the word aldosterone in it, so that's how you can remember that aldosterone is also being stimulated. And last but not the least, angiotensin is going to act on your hypothalamus and is going to stimulate thirst. Remember, it's going to stimulate thirst, hence is going to increase antidiuretic hormone. And we talked about antidiuretic hormone. It will act on these aquaporin 2. It will stimulate aquaporin 2 channels and cause increased water reabsorption via the principal cells in the collecting duct. So guys, this was basically everything about your regulation of renal blood flow and GFR and the RAAS system and juxtaglomerular apparatus. So I hope you guys understood this, and it's a bit complex, but once you have listened to this video, if you go back and watch your videos, read your notes, read your textbooks, it's going to make a lot of sense. So thank you for watching this video. If you stuck till the end, you did great, and I hope I made things easier for you. And let me know if you want me to teach any other topic which you want me to make easy. So let me know in the comments, and please subscribe if you like this video, and please like it too. See you guys soon. Bye.